I'm Addie Faerber. I'm the Executive Director for the Academy for Surgical Coaching, and I've seen some interesting themes come up so far. The need for a pathway to build independence in surgical trainees, the need for individualized learning, and also this question that's been left unanswered so far: what is the mechanism for change? How can surgeons change their practice in response to these sorts of feedback? I argue that coaching is one way to do that, and I'd like to explain in a little bit more depth. My apologies, I seem to not have a disclosure slide. I do need to disclose that the Academy for Surgical Coaching is a non-for-profit organization, and we do receive funding from one medical device manufacturer, that is Johnson & Johnson. I won't be talking about any of those products or any of that collaboration in this presentation. So briefly, I'd like to give you an overview of coaching for surgical trainees and talk about how coaching can support the learning and independence for surgical trainees. 3 key takeaways from this presentation. First of all, that surgical coaching is a process for improving surgeon performance. Second of all, that surgical video is a type of evidence, it's a tool that we can use. And third, if we're going to use this effectively, we have to overcome some pretty important barriers in practice. So I hope I've piqued your interest. If not, chill out for 8 minutes, check your phone. I'll be back, I'll let you know when it's time to come back. Make dinner plans or something. We'll figure it out. Continuing on. A brief orientation to what is surgical coaching. On the right, you see a Venn diagram outlining the differences between a surgeon, a surgical coach, a teacher, and a mentor. Surgical coaching is a learning practice where surgeons improve their performance with working with a trained surgical coach as their guide for their own personal improvement. A coach is there to support thoughtful changes to your practice while giving surgeon the space to reflect and to start to think differently about what they're doing, how they're doing it, and why they're doing it. Surgical coaching is different from teaching and mentorship in that the surgeon really is driving the learning here. And it's a way for surgeons to develop independence, both as a trainee and also throughout the rest of their practice as a active surgeon post-training. Surgical coaching is different from leadership, executive, and wellness coaching in that we focus on operative skills, OR team communication and performance, clinical decision-making, and self-regulation. Trainees can benefit from teaching and mentorship and coaching throughout their entire learning career as they transition from learning surgery to learning how to be a surgeon. So going a little bit deeper, as trainees grow their knowledge and develop independence, coaching can help support this building expertise. Here I show the Erickson Model of deliberative practice. I think we have seen this one many times in surgical education. The important thing here is that the coach is here to guide the surgeon through these cycles of personal improvement, to help them to create a vision for where they want to go with their practice and set goals to achieve that vision, asking deep questions to build reflection on what they're doing, and to keep that surgeon accountable to improving their performance. Briefly, I would like to review the research base that demonstrates the effectiveness of coaching to support surgeon development. A growing body of evidence from clinical studies has shown that surgical coaching does support technical and non-technical skills development in residents, fellows, and practicing surgeons. Surgical coaching is feasible and is well rated compared to other types of educational activities. We also know that surgical coaching can help with the safe adoption of beneficial techniques. We've shown this in TEP hernia repairs, in lateral approaches to the spine, and in anterior approaches to shoulder surgery. There's a lot of potential to continue to improve the way that surgeons work with their team, and also to start showing evidence of improving efficiency and improving surgeon well-being. Better surgeons do better surgery, and that results in better outcomes for patients. In process, I do have to put in a plug for the ongoing randomized controlled trial that we are supporting with the ACHQC. We're evaluating how much coaching improves performance change in addition to video feedback. If you're interested in learning about that, please get in touch with me. We would love to enroll more surgeons to help that trial to be successful. So this leaves open the question of how can video and video assessments make coaching even more effective? Operative video is a tool that we can use to allow coaches to make observations, to assess surgeon performance, as Jonah talked about previously, and to support reflection following operations. Just like how the team goes onto the court and plays on Tuesday and then gets in the locker room on Wednesday and reviews the video, just recording and watching yourself is already a valuable tool for performance improvement. However, use of video technology in coaching gets over one really big hurdle: how to get the coach in the operating room. Getting the coach in the operating room has issues when it comes to travel, especially with travel restrictions. It helps with overcoming credentialing issues, and it also can mitigate any concerns about Hawthorne effects, where the OR team feels that they're being observed and does things differently. Additionally, unlike teleproctoring, telementoring, etc., coach and surgeons review their videos after the procedure. It gives the time so that the surgeon doesn't have to focus on their actual surgical performance. They can have more space and reflect more. Video-based coaching also can help raise and also help reduce some of these medical legal challenges. Health systems are integrating video throughout ORs. I think SAGES and many of you are really at the forefront of this, but it has yet to penetrate to other areas of surgery. We also need to be able to use video as a tool but still overcome the concerns that are rife with discovery and malpractice with video. And also, we need to be developing better exchange platforms so that we can securely share these videos, so we can make them anonymous, so we can annotate and comment and use them as a more effective tool. Last, surgical coaching via video can help break down geographic barriers, so that the coach that you can work with, the trainee or the surgeon can work with, is the best coach for them, not just the coach that can get into their OR. So next, I want to explore some of the possibilities in 3 example programs that are integrating coaching and video. My apologies for the very sparse slide. I didn't have as many details when I needed to submit these a few weeks ago. Kara King at the Cleveland Clinic, shown on the left, has an interesting program for gynecologic residents and minimally invasive gynecologic surgeon fellows. Cleveland Clinic already has 2 of the 3 pieces in place for great coaching. One, they have ubiquitous video recording and abundant technology in their operating rooms. Second of all, they have a Center for Excellence in Coaching in Healthcare Professions, which has done widespread training. So Dr. King has been able to use these tools to formalize this as part of her program and her training for fellows, and helps them to build independence more rapidly. We hope to have results from the first 2 cohorts in summer 2022. Andrea Williamson in the center at University of Utah has launched a resident coaching program. Andrea, in fact, is a third year student to going into her research residency years. And she said, "I'm having struggles trying to get as much learning as I can out of every single case that I do. How can the few cases that I do get to do, how can I learn the most from it?" So we are training their faculty mentors in the principles of coaching. They're integrating video throughout the cases that the residents are doing so that they can also have formative assessments like we were talking about previously. Get the most out of every case for the residents, and coaching is a key component. Deborah Nestle on the right runs the University of Melbourne's Masters in Surgical Education. This is a program that trains future surgical educators and has integrated coaching throughout their curriculum, both as an educational method to help surgeons learn surgery, but also as a tool to help these developing educators improve their educational abilities. They coach throughout, and I'm eager to see where those surgical educators can go throughout Australia and improve things there. There's a lot of potential, but I've also identified some key issues, some key barriers that we must overcome in order to really build video-based coaching into different health systems. First of all, coaching is something throughout a surgeon's career, from trainees to fellows to practicing surgeons, and in fact to retirement surgeons giving back as coaches. This is something that should become a standard practice for many, many surgeons when they want to figure out how to change. We also need to tackle the medical, legal, and cost barriers to video in the OR. The best thing I think we can do is start by getting smart people together and coming up with some example documents that we can spread, things like consent forms, institutional policies, ways of communicating to patients about what's happening. Additionally, busy surgeons can't find time for reflective practice, and this just breaks my heart because time is what is the basis of being thoughtful and being able to learn and grow and change. So institutions that believe in this, that really want to help their workforce to have greater wellness, less burnout, improve their outcomes, should be giving surgeons the time to be doing these types of deliberative activities. And last, we have to close those loops between performance and outcomes. Because it doesn't help if you get outcomes information that's aggregated across your team or is coming in 6 months late. In order to have effective coaching, we need to know now if the changes that we're making are having an effect. And I think if we can overcome many of these barriers, that coaching can start to flourish in surgery. So for those of you who've been on your phones for the last 8 minutes, come on back. I'm about to wrap up. Wanted to get the key takeaways here at the end. Let me know what dinner plans are. In summary, my points were that coaching is a process for improving surgeon performance by working with a trained surgical coach. Surgical video is a valuable tool to help facilitate this type of learning, and that we really need to push to overcome some key barriers to making coaching more widespread, including integrating it throughout, addressing the medical legal issues, giving time for this, and getting better outcomes information. So thank you.